So let's continue talking about acute headache. The workup. The workup in acute headache. Non-contrast headache. CT. Non-contrast head. CT. MRI. Magnetic resonance phenography. MRV brain. Lumbar puncture with CS fluid analysis. Visual acuity and intraocular pressure, ESR, carboxyhemoglobin. So the workup we have non-contrast CT head, MRI, MRV brain, lumbar puncture, visual acuity and intraocular pressure, ESR, carboxyhemoglobin. Let's say the exclusion to the secondary cause of headache by that study. We say the test and the secondary cause to exclude with. We have non-contrast CT head, non-contrast CT head to exclude trauma, subarachnoid hemorrhage, CNS tumor or mass. MRI and MRV brain to exclude cerebral, dural venous thrombosis, pituitary apoplexy, hypertensive encephalopathy. The lumbar puncture with CSF fluid analysis and opening pressure to exclude meningitis, subarachnoid hemorrhage, idiopathic intracranial hypertension. Visual acuity with intraocular pressure, acute glaucoma. Erythrocyte septination rate, ESR, or temporal arteritis. Carboxyhemoglobin in carbon monoxide. The management. Let's repeat the test again. We have CT without contrast, MRI, MRV brain, lumbar puncture with CSF fluid, visual acuity with intraocular pressure test, ESR, and carboxyhemoglobin. Any test to exclude secondary cause for acute headache. We have non-contrast CT head to exclude trauma, subarachnoid hemorrhage, CNS tumor, and mass. MRI, MRV brain, and cerebral, dural venous thrombosis, pituitary apoplexy, hypertensive encephalopathy. Lumbar puncture with CSF fluid analysis and opening pressure, meningitis, subarachnoid hemorrhage, idiopathic intracranial hypertension. Visual acuity with intraocular pressure to exclude acute glaucoma, ESR in temporal arteritis, carboxyhemoglobin, carbon monoxide. So what is the management? The management for acute headache. We have pre-hospital care and hospital care. Pre-hospital care, the generalized recommendation includes the following: electing a basic history, evaluation mental status, performing a brief neurological examination. If there is any abnormality in the neurologic or mental state examination or if the patient appears unwell, emergent transport should be activated. In the field, the initial approach includes making the patient comfortable prior to giving medication. Patient should be comfortable. Adjusting temperature, minimizing unnecessary light or noise, placement into comfortable position. Acetaminophen can be used as a first-line medication. So the first-line medication is acetaminophen. In his hospital care. In hospital care, secondary headache must be excluded first. Secondary headache must be excluded first, as we said before. The primary headache. The management of primary headache. The non-steroidal anti-inflammatory drug is the first-line therapy for migraine headaches. For the mild pain, ibuprofen from the 400 to 600 milligram per oral. Consider sumatriptan 100 milligram per oral or 6 milligram SQ. For severe pain, diphenhydramine 25 milligram IV and prochlorperazine 10 milligram IV or metoclopramide 20 milligram IV, and consider dexamethasone 10 milligram IV and IV fluid, triptan, and consider expert consultation. There are contraindications for triptan use if there is uncontrolled hypertension, ischemic heart disease, mental angina, cardiac arrhythmia, multiple risk factor for atherosclerotic vascular disease, primary vasculopathy, basilar and hemiplegic migraine, use of ergot in past 24 hours, use of MAOI or SSRI, use of triptan in past 24 hours. The management of cluster headache. Acute abruption therapy for cluster headache fall into two groups. 1. Oxygen, 6 to 10 liter face mask, and sumatriptan, 6 milligram SQ, subcutaneous. Medication for primary headache, dosing, and American Academy of Neurological Quality of Evidence. The medication, and we have the dose. The disposition to set return precautions. Patients should be given return precaution for red flag signs and alerts to dangerous secondary headache. New headache in patient, as we said, new headache in patient older than 50 years of age, maximal intensity within minutes of onset, posterior headache with neck pain or stiffness, change in vision and consciousness, syncope, history of HIV or immunocompromised, history of malignancy, history of neurologic or cerebral shunt, pregnancy or postpartum, headache with seizure, follow up with the primary doctor. Thank you a lot. But I want to read this table. The medication for primary headache dose. The medication ibuprofen per oral 400 to 600. We have aspirin per oral 1000 milligram. Naproxen per oral 500 to 825 milligram. Ketorolac IV 15 to 30 milligram. Acetaminophen per oral from 900 to 1000 milligram. Aspirin, acetaminophen, and caffeine 500 milligram. Aspirin 130 and 500 milligram per oral. Dihydroergotamine IV 0.5 to 1 milligram IV. Chlorpromazine IV 0.1 milligram. Metoclopramide IV 20 milligram. Prochlorperazine 10 IV milligram. Sumatriptan subcutaneous 6 milligram. Sumatriptan per oral 100 milligram. Opioids varies. Dexamethasone per oral or IV 6 to 10 milligram. Thank you a lot.